Hello, everyone. Dr. Hess here. We're going to be covering chapter 13 and 14 this week. So lots to read, lots of interesting things. So let's get started. Here is chapter 13. Get our slideshow going here. So chapter 13 has a neurodevelopmental, disruptive conduct, and elimination disorders. These are usually disorders that are seen in childhood and early adolescence. As we go along, we'll talk about some of the ways that we can diagnose intellectual disabilities and learning disorders, and we'll talk a little bit about autism and ADHD. So intellectual disability, according to our textbook and according to the DSM-5, is below average intellectual functioning or deficits or impairments in intellectual functioning or cognitive powers. Often these intellectual impairments come along with impairments in communication, some social skills or relationship skills, and even some motor impairment. Some of the more well-known intellectual disabilities are Down syndrome, PKU, and Fragile X syndrome. A lot of our intellectual disabilities come because of environmental factors that happen prenatally. Before we are born, something happens in the environment that the mother picks up and is causing some kind of teratogenic effect to the fetal individual. I'd like to say that most intellectual disabilities are not reversible, rather than all of them are. So I don't want to paint that broad picture as our textbook does, or these textbook slide does for us today. Some of the learning disabilities that our textbook goes into that you might want to read more about is dyslexia and dysgraphia are probably the two most common learning disabilities. Our textbook goes into some of the treatments for specific learning disabilities. Autism spectrum disorder is defined by our textbook as deficits in social communication, social interaction, and the presence of restrictive or repetitive behavior patterns. Autism is often a lifelong impairment, not always, but it can be. For treatment for autism, I think first-line treatment most often is behavioral interventions as early as possible, as early after diagnosis. Positive reinforcement and shaping of good social behaviors and being able to interact with others is important early on. ADHD is another one of our learning disabilities. There has some inattentiveness that is seen in individuals that have ADHD. Oftentimes there's some impulsivity also. 3 to 5% of the children have ADHD, and it's usually diagnosed early in elementary school. treatment of ADHD is usually some kind of medication, some kind of stimulant medication that will help in a kind of a paradoxical pharmacological effect where the stimulant actually helps people who have ADHD slow down and be able to concentrate. Conduct disorder or oppositional defiant disorder is usually seen in children where there's repetitive or persistent patterns in which they bully other kids or tend to not take other people's feelings into account when they're working things. Oppositional defiant disorder is a pattern of being angry or irritable. Oftentimes this can be disguised as depression in children, but this kind of defiant behavior and vindictiveness is seen in that particular disorder. Enuresis is the first elimination disorder that we're talking about. This is basically urination into one's clothing or bedding, oftentimes at night, but it can be at school other times also. Encopresis is the basically passage of feces into inappropriate places over the age of 4. So past the time normally that most of us would be potty trained. That brings us to the end of this chapter. Let me bring up the next chapter here. Let me find it. I'm having a hard time finding it here. Hold on. I can't seem to find it. Hold on. Let me try again here. Sorry about this. There it is. 13, chapter 14. Here we go. Sorry about that. Here's chapter 14, Aging and Neurocognitive Disorders. So geropsychology, or working with helping people that are older, is kind of a career that there'll be a lot of opportunities in the future, considering the aging of, at least in our country, but there's more and more older people over 65 that we're having most of the time. That will need psychological help as they grow older, specifically with substance abuse or depression, which seems to be more prevalent in older adults. Also, we want to look at some of the ability of stroke and brain problems that we could have, and delirium that can cause problems for dementia and Alzheimer's disorder, all things that neurocognitively aging populations have to deal with. About 20%, 14 to 20%, according to our books, of older adults living in the community have a psychological disorder or a substance abuse condition. The criteria for older adults is the same as for adults and younger adults. There's no difference, even though we may want to treat it a little bit differently, either with different kinds of talk therapy or different kinds of medication. We want to make sure that we are able to treat the aged people for their depression, because depression can cause problems such as poor recovery when they have injuries or illnesses as they get older, and oftentimes older individuals have more healthcare needs. And if there's an underlying depression, it can cause longer recovery times. So some of the things that older adults are worried about that can lead to some anxiety disorders are of course, their health. As their health starts to fail as the older they get, the welfare of their loved ones, fear of falling, balance becomes an issue, and strength becomes an issue as we get older. Also, some stressful life transitions, maybe leaving the home they've lived in for a long time to move into a group home or a nursing home. There have sometimes problems with caregiver responsibilities, where they are actually taking care of their older parents at the same time. They have reduced income if they have not saved enough for retirement, or have increased medical bills. And of course, facing their own end of life issues can cause a lot of anxiety. Again, some of the same treatments that we would have with younger adults we see here in older treatment plans. Some of the most common substance abuse related problems are the overuse of alcohol and the misuse of their prescription medications. The older we get, the more it seems like the doctors are prescribing more and more medications for the things that are bothering us, and these medications can be either intentionally misused or accidentally misused. Tobacco is also a big problem for a lot of older adults. Of course, this leading to issues with lung issues with breathing, COPD, lung cancer, asthma, and the such. Delirium is an acute or sudden change in attention or awareness. This is disorganized thinking and sometimes disorganized language. This is something, a neurocognitive disorder in older people, that can be very troublesome because of the acute or the sudden onset of it. Oftentimes, the reason for this delirium can be the use of medications, also infections, neurological disorders, malnutrition that can happen, sometimes dehydration. So we have major neurocognitive disorder and mild neurocognitive disorder. Both of these are characterized by kind of decline in previous level of performance in various cognitive domains. In other words, being able to do things or think things through, being able to do math problems, crosswords, all of those things that we used to be able to do can, as we get older, our brains will have problems in these disorders will show up either significantly or some kind of mild kind of um, dementia-like things, or Alzheimer's-like in the severe um, case. Most of the time, it is a gradual onset of dementia and progress to Alzheimer's. Not always, but Alzheimer's is the most common subtype of neurological disorders, with up to 75% of all neurocognitive disorder patients. Lots of research about Alzheimer's going on. Probably most of us have had one family member or know of someone that is suffering from or suffered from Alzheimer's. Alzheimer's is a brain disease which is terminal, and it's hard to diagnose, and we don't have a cure yet. Hopefully soon we will. And that brings us to the end of this chapter. All right. Thanks for doing. That's a fast 2 chapters. Thanks for being with me, and I will see you next week. Bye for now.